Alright, I'm Madison Adams, and this is my final project for chlorhexidine versus alcohol. So, 250,000 bloodstream infections are acquired annually from peripheral and central lines. Peripheral lines are contaminated more than central lines and are 3-to-1 ratio. The more IVs that a patient has puts them at greater risk for infection. I know down here we normally place 2 IVs if they're going to the ICU or anything like that, so that's doubling their risk for infection. I'm going to talk about the safe skim prep for IV insertions, the proper equipment that we need. We're going to discuss the contamination rates. I plan to implement a new process and increase patient satisfaction. The rationale for this project is proper preparation for IV site can decrease a patient's risk of infection, decrease the number of contaminated lab specimens, decrease the number of sticks a patient receives, and improving these processes will decrease spending costs in the department and increase patient satisfaction. How many of y'all have to restick a patient when you get a patient from EMS that comes with a line?
Every time.
Pretty much every time. And definitely if you need blood cultures on a patient, you're going to have to restick them. So by implementing this process, I hope to decrease the amounts of sticks that we have for patients. And by properly cleaning IV sites, then we decrease the cost of it in the department so that we don't have to keep reusing supplies, and also we increase the hospital costs. If they get an infection, then we get reimbursed for that. Or if they get an infection, we don't get reimbursed. So the question is alcohol or chlorhexidine more effective in prepping sites for IV lines? Evidence shows that chlorhexidine prep lines produce the lowest number of catheter-related bloodstream infections, 2.3 per 100 lines started. Alcohol, 7.1 per 100 lines started, and iodine is 9.3 per 100 lines started. So obviously chlorhexidine has a lower risk of infection. Potential infections start with the insertion of the line. Prepping the site with chlorhexidine reduces skin bacteria more than 50% compared to iodine or alcohol pads, which only remove 10% of the bacteria. Skin should also be scrubbed for a minimum of 30 seconds, and you should want to scrub it for 1 minute for optimal results. Lines placed in pre-hospital setting are often hastily placed and improperly cleaned. This is talking about EMS, fire, flight, anything like that. Different catheters and claves and extensions are also used by EMS and fire and flight. This can also lead to contaminated specimens, hemolyzed specimens. Once again, additional sticks for the patients, and now you have to, when you have an additional stick, it also increases the rate of infection. Every line placed in the ER should be prepped with chlorhexidine. I would like for pre-hospital personnel to be educated on the benefits of using chlorhexidine and the equipment that we use. That way that we can have continuum of care between their pre-hospital treatment and their treatment in the hospital. And we need to review the current policy of keeping lines placed by EMS. If they prep it the way that we would prep it and use the equipment that we use, then we could use their lines a lot longer and wouldn't have to restick the patient when they get here. And also accurate documentation of your line. I know we have the vertical zone process, so if you get your patient back to your room and you need blood cultures, accurate documentation that you use chlorhexidine could also save the patient a 3rd stick. So how do we evaluate this? Reports can be made regarding contaminated specimens and prep used. We always get lab results and we know if they're contaminated or not, so that we can look at which prep was used, whether it was alcohol or chlorhexidine, and then compare if they were contaminated due to that or for some other reason. Infection rates for lines placed prior to arrival should be monitored for at least 6 months after the initiation of plan. So if we see a decrease in infection from EMS using our equipment and our chlorhexidine, then for 6 months we should see a change in that. And then of course chart audits should be made to evaluate the use of chlorhexidine for placement in the ER. we all know our audits can tell us. This is where accurate documentation comes in play too. So the outcomes that we should foresee in here is that bloodstream infection should be decreased. Once again, calls for repeated lab draws and longer admission should be reduced, and congruence of care from pre-hospital treatment throughout the admission. And then ultimately, patient satisfaction should be increased because we're not having to repeatedly stick them and stick them and stick them. And these are my references. Y'all have any questions or anything? Yes, ma'am.
I have a question. I wonder if you have access to the figures on how much money is wasted or could be recouped annually in an institution like ours if we used all chlorhexidine prep and did the measures that you described.
One study does say that chlorhexidine does cost about, I think it's 13 cents more than an alcohol prep pad. But, I mean, if you think about how many IV lines we start, and if you think about how much infection, like a cost of, yes.
I know for a fact since I'm doing the blood culture contamination issue project.
Okay.
One contaminated blood culture costs the hospital approximately between $6,000 and $8,000.
Oh my gosh.
There you
One
go.
contaminated
Well,
blood.
dollars is the language of administration.
Mhm.
So I was just thinking getting some exact cost would be a good follow-up project to this if you ever need to do one.
Yeah,
Sounds like that's
if you
being
think
done
about a
also.
sepsis workup, though, like if a patient gets a central line infection or an IV line infection, like their cost of just admission in general is going to go up because they're
Yeah.
going to be here a lot longer.
And we eat it too,
Yeah.
for the lack of
Yeah, because
compensation.
hospital won't reimburse us if they get an infection. that
Not to
they-
mention
from
the
us.
human cost.
And then you have the patient who doesn't have any IV access. You stick them 5,000 times,
Every time
and you're
we stick 'em.
wasting
Yeah.
all that material.
I thought it was interesting though that central lines were less contaminated than IV lines, but I did more research on that, and that was just because most of the time in a central line setting, it's
All the
calmer
care.
and you're in a sterile environment. Whereas an IV line, if you've got somebody cardiac arrest or SVT, just get a line in them so we can give them meds. So if we all have chlorhexidine, we can start carrying those around in our pockets and scrub it away. Okay. Thank you,
Good
guys.
job.
Yay.